first question is the same as how the patient interviews is done. It's basically general information, kind of like your story of how you got where you got.
Mhm.
So education, experience, the different things you specialize, um, how like you basically, I mean, if you want to talk about what made you want to get into that, that would be great. And then
Sure,
that we'll move on to the specific questions.
sure. So you want me to start with that, just
Yeah.
with my
Yeah.
background? Okay, so I'm a neurosurgeon. My specialty is vascular neurosurgery. So I'm one of the first people that started doing open, where we do open surgery, craniotomies to treat aneurysms, AVMs, and other types of diseases of the blood vessel in the brain and the spinal cord, to start doing endovascular. So neurosurgeons traditionally just did the open, and endovascular was in its infancy. And so today, about 80% of patients with those diseases are treated endovascular. I mean, we can just go through the wrist or the groin without opening the head.
Mhm.
And, it was a whole road and controversy amongst our colleagues during that time, which was, I felt blessed to be through, because it was a very interesting time. And I really, that's what I'm known for the most part. But I actually am known for Chiari now, just because when I first finished my training, which is I did all my neurosurgery training at Thomas Jefferson University in Philadelphia. I was a resident there, a fellow there, and then I stayed on and became the division director for the vascular program. And very early on, I remember one of my colleagues who did mostly spine. He said, "Hey, do you like Chiari's?" I said, "Yeah, I like Chiari's." And he goes, "Okay, great." And I'll never forget. We were in the hallway in office hours. Slapped me on the back. He said, "Congratulations, you're the Chiari guy." I mean, true story. And really, the reason is most surgeons, they don't mind, they like the surgery. What they don't like is that you have to deal with it. It's not just one and done surgery. It's if you're doing it right, you really have to help the patients. And it's I'm glad that you brought up that, this kind of bringing together this bridge of patients that have, questions and are frustrated, and the physicians on the other side of it. Because I can tell you, it may not always come out with every personality is different, but I don't know any neurosurgeons that don't want to help patients. And I think when they get frustrated, when they don't have an answer or something doesn't go well, that's kind of where I think things get into the gray area. um, so I started doing it, and I realized I was in that period where the way I was taught to do Chiari's, even then, without knowing anything, I'm like, this isn't right. Like, these patients don't do well. The surgery didn't even make sense for the pathophysiology. So I kind of dedicated myself at that point, first and foremost, I said, if I'm going to do this, I'm really going to do it well. And I'm going to make sure that it's not just a surgery and then go see a neurologist. I don't know, why you're having these problems, but to really build a comprehensive approach to the patient. And then also really figure out a way that we could do a better surgery with better results. And the problem, and you may have heard me say this before, is that there's not a lot of Chiaris. So if you take the amount of neurosurgeons, the amount of centers, and the amount of Chiaris that are done, it's so watered down that there's really no neurosurgeon that's doing 100 Chiaris a year or two. And if you are, that's a whole nother problem, because then there's just not that many patients out there that should be getting surgery. So that's how I got into the Chiari. And it's right now, at this point in my career, it's a large chunk of what I do. And that's where I really made the decision to start the support group and start this program, and to really get involved with organizations like ASAP. My physician's assistant, Haley Fitzgerald, was instrumental in helping put all this together, and set up our first 5K run locally here. Really was the kind of brainchild behind the support group and getting it to where it is now, where it's actually international. And so it's great. It takes a team. And so this is a large part of my practice.
I know for the group, every month we do a post for it in my group. So part of them, a good chunk of them, it's nice seeing them come in. So
Which is great. Yeah.
a lot of people appreciate it. We kind of, when you were going over that, we kind of answered question number 2 as well. So we're going to go to 3. So quite a bit of the research on Chiari surgery and the outcomes, it still focuses on the headache rating scales. The vast majority of the patients, they generally experience a much wider range of symptoms. So things like the autonomic dysfunction, connective tissue complications, and other like immune issues. In your opinion, how can the research community be encouraged to ask questions and measure outcomes that reflect the full experience of the patients?
That's a great question. And that's kind of the, getting into what I was talking about before, like just delving into this isn't as simple as, there's tonsillar herniation, you take care of the tonsillar herniation, whatever. So we started doing these intake forms on every patient. And we're not just, headache to me is the least, I mean, it's the most, the neurosurgeons are so focused on it because that's 90% of the time what brings patients to them. Is headaches. And then they're dealing with the neurologist or primary care doctor gets an MRI, they see this and it goes from there. Headaches to me, I will always try to treat the headaches as headaches first before we even talk about surgery. But what we're starting to look at is the not only the autonomic response, but also the cognitive memory, that brain fog, and those are really detailed questions. Depression, pain, not headache pain, but body pain, focal things, so that it's really helped us to see, especially now, the before and afters of patients that have come in before surgery, then after, to see what's getting better and what's not objectively. So that's why, because the number one reason people are operated on for Chiari's headaches, and the surgeons have kind of, I think, focused too much so on that.
Yeah, the vast majority of patients, if you ask them, they're like, I can handle the headache. The headache is, I can ignore that. I've had it for so long. It's whatever. It's the other things. I had talked to a surgeon and I asked him why it was that he particularly focused on the headaches. And he had said, because that's the thing that's the most consistent of the symptoms.
Yep.
And I find that kind of interesting, considering that the more patients you talk to, the more the other symptoms are very, very, very consistent. I think there's like this impression that the headaches are the most consistent because the others are not being tracked. That's just my own little opinion. But
no, and I think it's there's truth to it, because listen, putting the shoe on the other foot, any neurosurgeon, the worst thing that you can do is, we're not talking about knee surgery, or this is a very, very intensive, and it's not a small thing, because the risks can be very high. They may be a low percentage, but if you're in that low percentage, they're high risk, stroke, brain damage, injury, things like that. So one of the things that you really want is to make your patient better. And one of the things that you can sink your teeth into is the majority of patients that, if they are clearly Chiari related, they get better after. And some of the other things are more difficult to deal with. And I think the neurosurgeons are like into this kind of gray area where they want concrete things. They want, if I'm doing brain surgery on you, I want to be able to tell you that there's X percentage that this is going to get better, this is going to get better, this is going to get better. It gets much more difficult when you're talking about things like brain fog, autonomous regulatory issues, even visual problems. It just becomes a little bit more of a gray box. So hopefully we'll be able to get some data that shows this is a percentage in this type of patient of things that will get better or may not get better.
Right. And that makes me really hopeful for the studies that are coming out of, like, Bobby Jones is doing some studies and down at WashU and stuff. So hoping that they come out with some pretty good stuff. Next question. Undergoing brain surgery, particularly for those that are having it for the first time, it's generally the scariest thing they're ever going to experience. It requires the most trust that any of us will ever have, just a place in a person in general. What, if anything, do you do to show your patients that the surgery is, one, worth overcoming their fear, and two, that their trust is a safe thing to give you?
Yeah, no, that's another great question. And I think it gets back to what I was talking about, just previous to this was, being able to have an honest conversation, and listen. Really the majority of my first patient visit is listening to really understand, and not in my brain be like, okay, well, that doesn't fit in the Chiari bucket. This does, that doesn't. Just listening so you can kind of get a 30,000-foot view. And always, the first thing I reassure my patients is that, this is something that is treatable. And even if it's not surgery that's required, we'll deal with the symptoms. It's not just, oh, well, you don't have a Chiari or the surgery's not going to help. Sorry, go find someone else. I think that's critically important. And also just not jumping into surgery. I think it's pretty rare, unless it's an extremely severe case, that my first visit, I'm going to say, okay, what date do you want to operate? Here's the consent. I don't do that. Patients need time to process this, and they need to, that's where, to me, in my experience, they get the comfort level where they kind of leave the office because we don't see it, but in the brain, in your brain, you're like exactly what you said, like, oh my God, brain surgery, this, that, my, it's like you need time to process that. So then you can kind of go back and you're not leaving with, I'm getting surgery next Tuesday at this time and I got to do research on it. And you give the patient the time. I think that's immensely helpful.
That I agree with. I'm seeing more and more in the groups that, like just the other day, I saw somebody that they had the diagnosis and 3 days later they had surgery for it. On top of that, it's like, I had brought this up in one of the support groups that we had a month or two ago, about the conception that surgeons, their job is to cut, and if there's nothing to cut, there's nothing to do. The problem with that is that there's a large chunk of surgeons that they seem to live by that. And it seems like the quote unquote Chiari specialists tend to actually sit down, listen, and they will kind of help you out and guide you a little bit more than the average surgeon. But the surgeons like that are not so specialized in the intricacies, they tend to just one and done, and then it seems like there's more problems afterwards.
Yeah, and that's why people go into surgery, right? So, I mean, most people, you pretty much clear your third year of medical school, which path you go into, and there's always a gray area, of course, but there's being a doctor and there's being a surgeon, and they're two different things, right? You can be a great surgeon and not a great doctor, and vice versa.
Mm-hmm.
So, people that go into surgery, their passion is, and I'm one of those. I love to operate. I love working my hands. That's what I do. But that doesn't mean it should be at the expense of those other things.
Right.
And so that's why Chiari, you'll find a lot of neurosurgeons, they don't, I give my colleague credit. Like when he said, do you want to do Chiaris? He was saying it kidding around, but like, basically what he was saying was like, this is not what I want to do. I like the surgery, but I don't have, this is just not me to do this and to spend this time. And I don't want the patients to get the short end of the stick. So I think people that do Chiari, one of the big problems is, and what I'm hoping to change is that understanding that Chiari is not just the surgery. That's the easy, and I say it all the time. It's the easiest part as a neurosurgeon. The hardest part is determining who should get the surgery and who shouldn't. And then if you do operate, I'm with me and my colleagues are very much, no matter what the surgery is, once you cut someone, they're your patient for life. Now, it doesn't mean you're going to be managing their flu shots and things like that. But that being said, you're there to answer those questions. Is it okay for me to get a flu shot? I'm having a headache. I'm having something even remotely related. That's your responsibility because you took on that disease by doing the surgery. And it's not fair to the primary care doctor. It's not even fair to the neurologist. And it's certainly not fair to the patient for them to get stuck in the middle of that.
Your group was the first group I've ever heard say that. And it was very kind of like eye-opening. I was like, oh, this is the group that I want to, work with in the long term, because I feel like The doctors that are doing things like this, more of the Chiari community need to see that. There's a lot that you'll see in the groups where they're like, oh my God, I hate these doctors so much. And
I get it.
I spend a huge portion of my time like advocating for the surgeons, and I almost spend more time doing that than I do for the other, Chiarians, which I feel like it should be the other way around. But, it was actually part of how this section of the interviews happen is how can you have a community and we are forsaking the part of the community that is actually trying to help? Because, like it or not, the surgeons are a part of the community and in a very important part.
Yeah.
So that's kind of how that happened. But yeah.
Yeah.
Next question. Living with a complicated diagnosis like Chiari is very overwhelming for the patient. So is the prospect of being abruptly thrown into a normal life after such long like disability, because the longer that you have Chiari, the patients, it does take a toll, and a lot of people don't realize how much. It's one of those like silent illnesses, the invisible illnesses. We all kind of hope that the surgery is just going to fix this completely. If you miraculously cured a patient who then felt ill-equipped to live life in the real world, what would you tell them?
So, I mean, I think there's a couple points to that question, and one is exactly that, which I've learned from my patients, over the years that, even patients that have incredible outcomes, the recovery time's longer than the surgeons think.
Mm-hmm.
And, I will kind of always talk about, it's, well, when can I expect to go back to work? And my answer is always, everybody's different, because it depends on what you as a patient are feeling, and everybody feels something different. It can be as mild as just, your energy's decreased for a while, to, there's a lot of psychological factors too with dealing with this. And I think the most important thing is setting expectations up front. And I think patients are so desperate, understanding that wow, there's a reason for all these symptoms I'm having, and I'm going to have surgery. And it's easy for the surgeon to be like, oh yeah, it's an hour and a half surgery, and you'll be home the next day, and you'll be back to where it's not spine surgery. It's not like other types of surgery where you're just healing from an incision. So I think setting that expectation up early, where they understand that it is, especially for some people, it's a process, and it can be up to a year or more process of recovery after the surgery. So again, it's expectations up front, and being a good, explaining that to patients.
That's a really good point. We've kind of built our own little timeline in the communities. It seems like after about 3 months, they start feeling better.
Mm-hmm.
Once they start seeing an improvement, and then about a year, they're actually like doing things that they used to do. And that's something that I think, a lot go into the surgery thinking, oh, I'm going to be great like next month. It's going to be fantastic. Unfortunately, there are surgeons that will actually tell people that. Like the surgeon that did my decompression, she released me back to work like 3 weeks later, and she was like, yeah, in a month you'll be fine. It was not the case, and that's
Yeah.
more common than not.
Yeah. The earliest for everything being perfect is 6 weeks. And even then it's like, that's when we sit down and, okay, how are you feeling? What's your energy level and all of that? So yeah, and it's really, you learn as a neurosurgeon, that's the last thing you want to do, because you set these expectations for your patients. And it gets back to why people focused on the headaches, because the headaches are usually something you get better immediately. For most people, not everybody. It depends. That's why it's really important to discern, are these migraines? Is it a migraine variant? Is it a Chiari? Because if you have migraine headaches, I don't care how bad your Chiari is, those migraines are going to still be there. And in fact, they may get worse, after the surgery. So that's the satisfaction as a surgeon that you get, is somebody's coming into you, they're suffering, you perform a procedure and they're better. But that's not the real world.
Yeah, I wish that was the more often cases, but
Me too.
So, based on your experience, can patients or their loved ones take any steps before and or after surgery to improve the mental slash emotional outcomes? Are there any non-medical interventions like temporary modifying the home, purchasing certain supplies that you think could improve physical outcomes? And if so, like, could you recommend any alternate therapies?
So it's and again, it's not a cop out, but every patient is different. So it really, that's where the individualization comes in, and the spending the time preoperatively going over everything, making sure they understand. So somebody that already has neurologic deficits, they're, even if it's just hand intrinsic weakness, which is very common, they're dropping their coffee mugs, they have that weakness. I tell them right off the bat, expect to have inpatient rehab. Expect it. If you feel like you don't need it after, or things get better, that's great. So I think it depends on what the patient's experiencing beforehand. Always finding out, before, do you live alone? Do you have a support system? And job is a big one, because that's a huge stress too. When people go in and they think they're going to be back to work in 2 or 3 weeks, and their job thinks that, and that's not the case. They end up losing their job, and then that just becomes this whole cycle. So you really have to individualize each patient with what their pre-existing deficits and concerns and issues are. And that's what's helped us as that intake form. Because some things that maybe even asking or saying I wouldn't notice, but when I see someone say that, I'm an 8 on the depression scale, like that's something to me that's like, okay, what is your support system? Spending a little bit more time about, what to expect. Don't get to, a big one is, don't worry if you're not better in the next week or 2 weeks or 6 weeks. This is a longer process. And even though patients may not want to hear that up front, it helps in the long run, because you're not waking up thinking, what's wrong? I'm supposed to be better already.
I will say a lot more patients tend to have a higher respect for what when we're told what we need, not what we want. Because
Right.
it's easy to just tell us whatever we want, and then we go into this like la la land, and then it just whew. Um,
Yep.
so I definitely think that they appreciate that more so. Um,
And
yeah.
it depends how it's said as well, what the delivery is. And listen, we're all human. And so everybody's personality is different. Some people, again, that's like, to me, the big difference between doctor and surgeon. They're two different things.
They're different creatures, and each specialty of each subsection of medicine is each different creatures too. It's like in high school when you have
100%.
the jocks, the geeks, the band. Yeah, it's all.
It's exactly right. And I will tell you that the stereotype fits for the great, not everybody, but for the great majority. I mean, you can go online and see some of these memes and things where it's like, an orthopedic surgeon, a neurosurgeon, a plastic surgeon, a neurologist, and because the personality traits tend to attract you into that, right? Like if you're into music and stuff, you're in that crowd. If you're into art and all that, you're into that crowd. If you're like sports, you're into that crowd. So it's the same thing in medicine for sure.
I will say the first neurologist I ever saw was wearing a bow tie, and then one of the biggest memes is that they wear bow ties and they're very nerdy.
Mhm.
Spot on, just very spot on. So.
Yep. Yep.
Um, so today's medical technology, it must have been very unimaginable to the neurosurgeons of the past generations. Where do you imagine neurosurgery will be headed in the future generations, and what would you like to see, in particular, anything in particular, technology wise, developed, or any obstacle that needs to be overcome?
Yeah. So, I mean, now, and I talk about this a lot in my lectures, that for the first time in the history of medicine, we have more technology than we know what to do with. When I was starting out, it was like, oh, if we only had this and we could only do this. And the reality is that there's very little we can't do now. But just because you can do something doesn't mean you should. And
Right.
I think there's a little bit right now we're in this opposite of just trying to shove technology into stuff that's not really helping anybody or anything. So I think we really need to focus on what is the problem and then start using it. But I would say AI, I would say that, right now, brain body interface and imaging of understanding pathways. I mean, what we can do right now, and really, I mean, ironically, which I'm not shocked, because if you look at most innovations in medicine, it's not from the doctors, it's not NIH, it's not the big universities at all. It's industry, it's people who can think outside the box. You know, brain body interface has been around for quite a while, but until Elon Musk said, we're going to, you know, this is what we can do with the imaging. I mean, with the chip technology, and then worked with neurosurgeons and said, no, 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 I'm not listening to you. I need you to do this. And he put this team together. And what you see right now, people with ALS that can't move from the neck down, they can literally sit and look at their iPad or their computer, and they can turn lights on and off. They can text with friends, and that's only going to increase. So I think that is really, to me, the most exciting part of where medicine's going, and particularly neurosurgery.
Yeah, some of the stuff that Elon Musk is doing with Neuralink and whatnot is very cool. And as much as that man is a little crazy,
Oh, he's 100% crazy. I mean,
I, I used
I
to
mean,
work with him. He's very, very, very out there.
oh yeah, yeah, no, he's beyond on the spectrum, but he's like a Steve Jobs or all these people where they live in their own world,
Mhm.
and but I think he's also realizing it's not as easy as he thought. Like there's the engineering component, but when you're dealing with the human brain and the human entity, it's a very, very, very complex thing. It's not as easy as just electronics and electrical stimulation, but has definitely advanced that field without question, regardless of what, as him as a person, he's pushed that to the next level.
It's interesting seeing the combination of engineering with medicine as well. It's very cool.
Which have been in silos. So, just as an aside, so that's something that I realized early on. And when we have medical students and students in the engineering program, you can immediately see that. And about 10 years ago, I got asked to lecture at the biomechanical engineering school at Drexel, and I was talk to these undergraduates. I didn't want to leave. Like these kids were. I mean, the way they were thinking, they weren't thinking like medicine. They weren't, a lot of times you get the medical students, they're just thinking, okay, I want to look good so I can be, you know what I mean? I don't want to use the word brown nosers, but it's a little bit different. The engineering students didn't give a crap about any of that. They're just like, why would you use that metal? Like, well, why can't you do this? Mesh. Like, why do you use mesh? And
Mm-hmm.
things that I was like, that's a really good question. So we developed a program called Engineers and Scrubs. So people that go into biomechanical engineering, almost all of them have a passion for it because of an experience in their life. They had a family member, a loved one who had a cardiac issue, a neuro issue, and they love engineering. So they're like, I want to invent something that's going to help people in the medical field. They get zero exposure to patients, to the hospital, to what happens in an operating room. So we did this engineering and scrubs, and it was really exciting. So I'm glad you brought that up. That's one of the things that we need to break those walls down and just have everybody that's not in the traditional space of healthcare in under one roof.
Right, right. So has your experience as a neurosurgeon taught you anything about life that has changed the way you look at or approach your own life?
Great question. These are great questions. 100%. I mean, particularly in neurosurgery, it is a very, very difficult. There's a lot to deal with, and it's not what people think about, like hours and the stresses. You're dealing. You have a side seat to watching the most devastating thing happening to a human being and to family and to loved ones. I mean, having to deal with patients that are going to die, that have incurable diseases, having patients come in electively that trust you, that you have your trust in, and under the best of scenarios, they wake up and they have a deficit. They can't walk, they can't speak, they can't. I don't care. There's no neurosurgeon that doesn't deal with that, and it becomes a really, really, really difficult thing to deal with. But I think over time, what I've tried to do is I look at it as a gift because it's helped me personally put everything in perspective. When I hear people complaining, I'm like, myself included, I'm like, I have nothing to complain about. I'm like, I just did office hours and had to tell someone they had a malignant brain tumor. Someone came in with a ruptured aneurysm, and I mean, these people's lives are upside down. So I think the passion comes in that you want to do everything you can to help them, not just surgically, but in every way, shape, and form. But it also gives you perspective in your life, because at the end of the day, we're all going to get sick and we're all going to die. And doctors and surgeons tend to think we're different until you get sick, until something happens to you or a loved one. Then all of a sudden it's like, oh crap, I'm human and I'm on that side of it too. So yeah, it profoundly changes you. It's impossible not to.
Right. And I think it's very important for especially us as patients to remember that surgeons are people too. The only difference between, like, say, you and I is that you had the opportunity and the want to go to medical school and then become a surgeon, whereas my path in life has led me down a different way. But here we are still at the same footing.
Absolutely.
So
100%. And I think the best doctors, and again, I'll take surgeon side, but the best doctors are the people that do have real life experiences, that have done other things and not just, I was a straight A student in high school, and then I went to this, and I just worked to get grades to get into medical school. Then I went to medical school where that bubble can put you in a very, I think, dangerous place as a doctor, because it's, medicine's not science. It really isn't. I mean, it's humanity, it's art. I mean, there's so many different important facets to it. So no, no question at all. And I will tell you, and I think most doctors will tell you, we are the hardest on the healthcare system because we know the inside workings, and trust me, I mean, we deal with the same nonsense you guys do.
yeah, I know a lot of people will get upset at the doctors for their medical bills, but it's not the doctors, it's the insurance companies, it's the conglomerates and whatnot. And
100%. And I can tell you, most centers, they spend their time fighting with the insurance companies behind closed doors constantly. I mean, these insurance companies are, you're talking, billions of dollars of profit. And listen, I'm not a socialist. I'm a red-blooded American, but at some point, something has to change with that. And that's where, you're right, the patients get stuck in the middle. And you imagine you are struggling with this life-altering medical problem or surgical problem. And on top of that, you're basically dealing with having to get bills paid and people putting liens on. I mean, it's like, that's a whole nother thing that I think most doctors do take personally, because it's a broken system.
yeah. So, do you personally have a sort of career bucket list? For instance, is there a procedure that you've never had the opportunity to perform? Have you wanted to work in a certain part of the world where with a specific organization? Do you want to branch out with what your education already is? Is there someone that you hope to pass along your knowledge to, or things like that?
Wow, these are these are great questions. So, so the answer is yes. I've been blessed in my career. I mean, truly blessed. Again, as I mentioned before, I mean, I was one of the first people to start doing these endovascular procedures, that no one else was doing at the time, and I just happened to be lucky to be in the right place at the right time. Chiari in of itself, we've developed a new technique, which again was based on, like, we should have better outcomes. CSF leaks should be lower. Let's think outside the box. So, and I've invented aneurysm clips, quite, like, I've done a bunch of that stuff. And as you mentioned before, longevity, like, we work with industry. So my bucket list, I will tell you, my two important bucket lists at this point in my career, and I've been doing this almost 30 years, is one, to develop a center, which is a hospital, but not a hospital, where everything is under one roof, where it's one-stop shopping. So let's talk about a Chiari patient, which is a perfect example. You walk into the door, it's where you're seeing your doctor. It's where you can get your rehab, where you can see your neurologist, you can see your a nutritionist, you can get all your imaging by the same team of people. And industry's also there, so that they're helping, like seeing patients with you so that they can understand, and we as a physicians can say, this is our problem, this is what we need to make better, go make it. Bring in education, so we change the way we're teaching medical students, what we were talking about before, bringing engineering students into this, so this kind of ecosystem that is neuroscience based but everything under one roof. That is very patient centric, and we're pre-COVID, we were very close to this. So that's my swan song. And then the other thing right now I can tell you is to find somebody that, you have to find someone who's going to carry on what you're doing, that's going to be better than you, smarter than you, that's going to think differently than you, but understand the bigger picture. So those are the two things that are on my bucket list.
Shoot, maybe I should become a neurosurgeon, come work for you.
You don't have to become a neurosurgeon. That's the beauty of it. I mean, to me, the least important part of this aspect is the neurosurgeon. It really is. I mean, it's all of these other pieces where people are aligned and everybody's doing what they do, but it's very synergistic. And it's the best word I can use is an ecosystem. It's an entire ecosystem where it's one-stop shopping. If you put everybody under that roof and everybody's aligned for the same thing, I mean, that's a game changer.
Like a medical mall.
Yeah, yeah, exactly right. A medical mall, it's a center of excellence that is not all about just the clinical, where everybody's there, where you can literally get on an elevator, go up 2 flights, and there's industry, name the Medtronic, Philip, whatever, imaging, and you can sit down and work together and say, okay, this is what we need to develop, and let industry, great, take it, market it, do it out. We're going to help you, but you're going to listen to us based on what the patient needs. And I'll be honest with you, that's what industry wants. They can't get into hospitals anymore. When I was training, before a lot of these ridiculous laws came into effect, we worked all the time with industry, but it was very clear. And that's why I'm very adamant now. I grew up in that world where there's a very clear line. I'm not going to talk to patients about something that I have a financial interest in. And if I do have a financial interest in it, I'm not going to do that procedure. I can talk about it and all of that. But we've gone to the other extreme now, where industry cannot even get access to doctors or patients, which is, think about that. It's like they're in the business of developing the next cure, and they have very little access. And the access that they do have, and being independent, I can say this because there's a luxury in not worrying about who you piss off. It's not at the big universities. I would ask all these big universities, like, look at COVID. I mean, listen, Hopkins didn't come up with the vaccine. Penn didn't come up with the vaccine. Harvard didn't. Way off. These were the people that were saying it's going to take 3 years and this and that. It was industry that came up with it. So we need to harness all of that and stop doing what we've been doing for the last 100 years in medicine.
Obviously, what's the definition of insanity? Doing the same thing over and over again and expecting a different.
Bingo.
Yeah. Yeah.
Bingo.
That's kind of what we're stuck in. You can't advance in technology or industry or any kind of field, regardless of what it is, if you're doing the same thing over and over again. Just because it's tried and true doesn't mean it's the best for growth and expansion. So,
yeah, I mean, and that analogy, if you think about all the diseases that we have no clue about, and if anyone's being honest, and I'll challenge anyone to tell me, Alzheimer's, Parkinson's, even stroke recovery, autism. I mean, you go down the line, ALS, all these neuromuscular diseases, high-grade glioma. So here's a fact: GBM, glioblastoma multiforme. The outcomes of these patients, there's been for the last 50 years, no appreciable difference. If you're sitting in an office 50 years ago to now, and you're telling a patient, it's going to sound pretty similar about what the outcome is. Yes, there's been some advances, but it's because we keep looking at the same thing over, and it's the same type of people looking at the same thing over and over again, as opposed to, like, look how penicillin was invented. Look at how the vaccines. It's like it's right under our noses, but it's just not obvious. Now, do I think Tylenol's? No, that's not no. But the point is, you have to disrupt that to say, okay, well, what you guys are talking about and thinking about is not working. And clearly there's a lot of these diseases that not only we don't have any clue about, they're getting worse and they're getting more prevalent.
Right. And that's kind of very sad, very, very sad.
Well, it's an opportunity. You can. It is sad, but to me, it's an opportunity. It's an opportunity. It's what gets my juices going. Of like, look, the fruit's really low hanging here. We got to do something different. But it's disruptive. You've got to be disruptive.
Yeah, I agree with that. So you've very obviously made a wonderful career for yourself as a neurosurgeon. If life had taken you down a different path and you couldn't have gone into medicine or a related field, what do you think you'd be doing today and why?
I would be a musician in a band. That was my original passion, which I'm not the prototypical neurosurgeon. If I truly had a guts and talent, I'll admit, I'll tell you that too. If I had enough talent, that's what I would have done, is 100%. So I would tell you neurosurgery for me was kind of I think very blessed, and I believe in fate. But that's probably what I would be doing.
That's kind of cool. You gonna sing us a song? No.
Oh, trust me, you don't want me to. That was part of the problem.
Well, I guess surgery is it's an art, so you're not too far off from your field, I guess. It's
Yeah.
yeah. So when your body and mind are failing you, it can be very intimidating to work with a highly educated doctor in an elite specialty. Can you share something about yourself that might make you seem a bit more human? For example, do you have a guilty pleasure TV show or a favorite cartoon character? Do you look for your sunglasses while they're on your head or regularly bump into furniture or anything like that? Do you have a cool pastime? Something that you could, tell people to just kind of.
Yeah, I mean, and I think that's a great question because we're all, as you said it before, you and I and me and my patients are not all that different. So the answer is yes to all of the above. I love South Park. Back in the day, Ren and Stimpy. I mean, and yes, I consistently have my glasses and sunglasses on my head, and my family makes fun of me relentlessly. But absolutely, I mean, I think any doctor, or anybody for that matter, whatever you're in, if you take yourself that seriously and you believe this hype or these stereotypes, that's the biggest danger that you can have. And there's a saying, don't believe your own hype. At the end of the day, we all have our frailties. Listen, God made us all. We're all damaged human beings, right? In some way, shape, or form. Everybody has their demons. Everybody's human. And the goal is, I think, for doctors, I'll speak for myself, my outlet is really being able to, help people. It sounds hokey, but like there's nothing more powerful. When I hear older doctors telling medical students or people who are interested in, oh, it's not what it used to be, it's thankless, don't do that, it really pisses me off because it's like there's no other job in the world, and I don't care if you're a pediatrician, a nurse, that you can wake up in the morning knowing that you truly make a difference in people's lives if you're doing it right, that you are truly helping people at a time where when you're sick, it doesn't matter how much money you have, it doesn't matter the color of your skin, it doesn't matter what your religion is, it doesn't matter what your sexual, we're all the same. When you're sick, you're sick. And that to me is such a strong bond. It always struck me as that. So yes, we are absolutely just as frail as human beings as everybody else.
I think part of the problem is patients tend to put their doctors up on a pedestal, particularly because of the amount of education and training and prestige like that you guys work for. So I think it's a good reminder to those of us that are doing that, hey.
Well, I'll share with you a saying that's very true, and it's an old saying, and it really is more with surgery than anything, but it's applicable to all of medicine. Treating a patient is a privilege, not a right, period. It's a privilege. I remind people when they complain, like, you signed up for this. Like, this is what you signed up for. And if you signed up, especially something like neurosurgery, because you have some misconception that this is this really cool thing to say, or you're going to make a ton of money, you are going to be very miserable because it is, I mean, it's a life commitment in a lot of ways, not just for you, but for your family, for your loved ones, for, I mean, the amount of time and energy, but also coming home after some of the things that I talked about. You have to, your family and loved ones have to deal with that aspect of it. So it's not as glamorous as it sounds. Again, I think most people would tell you if they could do it all over again, absolutely. Is it difficult to do? Absolutely. Can everybody do it? No. But that being said, there's a responsibility to it.
Right. So many patients who live with Chiari, they also have the overlapping conditions, EDS, MCAS, or dysautonomia. We know that these can make surgery and healing more complicated. From your perspective, why isn't there more emphasis on thorough preoperative testing and tailored postoperative support for this group of patients, and what changes could be made to better support them through recovery?
So what it comes down to is and this is on us as doctors, there's just not enough data to be able to say, what is 100%, there's correlation and then there's cause. And so you really have to sort those things out. I mean, for me personally, and this is just and I'm sorry, I'm just plugging in I'm going to lose my power here. The EDS is a big one. And again, my personal, it's not going to change. Like if you have a Chiari malformation and you're clinically symptomatic from it, EDS, whether you have it or not, the outcome's pretty much going to be the same. And I can tell you from a data standpoint, just doing a fusion on somebody up front because they have EDS and they might become unstable. I mean, outside of, seeing obvious instability, it's not going to change what you do. And I don't know if this is the right answer, but I try to unburden as much as I can for my patients. It's like doing genetic testing that, okay, you have it's either going to make a difference or it's not. And we certainly don't want to overwhelm people with, well, there's EDS and this could happen and you might need a fusion. Yes, you talk about all those things if they have EDS, but I don't screen people up front for EDS because it's not going to change what I do.
Right. And I've always liked the phrase, the right surgery for the right patient.
Yep.
I wish that it was more prevalent with the other surgeon. It seems like with surgeons, the specialists are the ones that have the information. And unfortunately, the average person does not have the ability or finances to travel to see a specialist. So there's constantly, you'll see online posts, hey, does anybody know of a specialist in this state? And it's very difficult because there's almost like a high risk of finding one that doesn't fully understand how complex it is, and you end up with more failures than not.
Mm-hmm. No, absolutely. And again, because the most experienced rheumatologist, endocrinologist, they have limited knowledge of Chiari, and most neurosurgeons have limited knowledge of all those other things. They know what it is within the spectrum of the patients they see. And that's why I think having these specialty centers is critically important. And what we try to do is with our second opinion site is to, at a minimum, get people to the right people with where they live. I mean, I've seen patients and helped them in Alaska, and some big places like Seattle, where there's like world-class, but they just don't know who to go to. And it's mind-boggling to me that sometimes their own doctors get either confused or, blow whatever. It's just, the more times than not is all we're doing is saying, well, Dr. Jones is, this far from you. Where do you live? And that's it.
I will say with your second opinion online, your group and Dr. Greenfield in New York are the only ones that I know of that do that. And so I send you guys your information out to quite a few people. I get a lot of messages saying, hey, do you know where I can find somebody, or do you know about this or this? And I'm like,
Right.
here's your second and third opinion. Go, you can run with that.
Exactly. So I'm happy to do a second session with you, but I'm getting like pinged right now for my 4 o'clock, I'm sorry, my 3 o'clock meeting here. So if you have and again, I'm happy to do another session with you if there's more questions, because I mean, I'm enjoying this as
Okay.
hopefully as much as it's helping your patients.
There is 8 questions left.
Okay.
So, um, I will take whatever time you will give me whenever you
Well, yeah,
want.
let's go because like next 5 minutes, I'm gonna have to jump off. But so let's go through them. You pick in order of what you want, and but I promise I'll follow up. We can do another one for all the questions.
We can do, I'll take some of the shorter ones and then we can just make this shorter.
Sure.
Um, let's go with the last 3. Um,
Okay.
is there anything you would like to say to others in your field who are doing more harm than good to the patient seeking help?
I mean, that's a tough one because I can honestly say I don't know anyone that's doing harm. But what I guess my message for Chiari would be if if you're not willing to see the patient for the rest of their lives, if you don't do more than 5 a year, refer it to somebody who does do more, and is willing to do all of that, because I think that's where the harm comes in. It's not intentional harm. It's, oh yeah, Chiari, I know how to do a Chiari decompression. And then it's all these other things coming up and like, whoa, okay, I didn't sign up for this. So that would, I think, be the best message.
Okay. Is there anything that you would like to say to the patients that you couldn't help?
Sorry. I mean, genuinely, I mean, that's, I think, for any doctor, and is the deepest wound is not being able to help somebody.
Yeah. And then the last question is there anything that you would like to say to the people who are just learning about their diagnosis, especially since this can be one of the most terrifying things to be told? We would love to hear your perspective, especially as the person that's treating it.
Be your strongest and best advocate, because you are. Don't be worried about upsetting it. Like if a doctor gets upset because you're asking too many questions or something, run. That's our job. So be an advocate. If something doesn't make sense, keep asking. If you're not getting the answer, move on. And it's not easy, but just get with someone that you're comfortable with, that's answering your questions. And these types of communities and the things you're doing are critically important, because people can share things. And I'm hoping there's going to be more second opinion sites. We're working on it with everybody. This isn't a competitive thing. That, the more quality, the better for everybody.
Right. So I appreciate the time that you took for this. I don't think that we'll need a second one because we really, the other
Yeah.
ones are.
But
It's
I'm
okay.
happy to help in any way, shape, or form. Thank you for doing this. Thanks for having me. And I hope to see you in the future. And I'll talk to all your folks at Longevity.
All right. Thank you.
Take care. Have a great day.